Good morning, everybody. My name is Greg Lotz. I'm KanTime's Director of Marketing and Sales Technology. Let's get started. I'd like to first start by introducing our speakers today. KanTime is joined by Mac Legacy with Lisa McClammy, a senior clinical education consultant. She's been in this industry for over 23 years as a nurse and has held various management positions along the way, and will be contributing her professional insights as to what is staying the same, as well as how Mac Legacy can support you. With her, we have KanTime's own Kim Spence. She is our customer success division leader. Kim has over 35 years in this industry as a nurse, and she too has held various management positions along the way. And we'll be going into detail on what the new rules say, how it will be enforced, and what KanTime will be doing to solve this challenge for all our customers. Kim, handing it over to you for further overview of today's webinar.
Thank you, Greg. Before we move on, I'm just going to review what we can expect from the webinar today. Lisa will talk to you about the things that aren't changing in 2021 and how Mac Legacy can help you meet many of your agency's needs in the coming days and beyond. I will review the changes coming for the new year and how KanTime will help you meet the challenges that agencies will face with the new regulations. So let's get started. Lisa, I'll hand it to you.
Thanks so much, Greg and Kim. Let's jump right in. We do have a lot to cover today. I'm going to get started with telemedicine. The reason that's being covered in this section is because this actually started as part of the COVID-19 waivers, and it's going to continue permanently as of January the 1st, 2021. I want to go over what's required with telemedicine so that everybody's up to speed on what they need to be doing if you're choosing to use telemedicine as part of your care of your patients. CMS specifically says that home health agencies can use telecommunications technologies in providing care to beneficiaries under the Medicare home health benefit. Now, don't confuse this with the face-to-face changes that allow for the audio-video telehealth to meet the face-to-face requirement. This is specifically talking about agencies having the ability to use telecommunications, which can be audio only or audio-video, to provide care to the patient. Any telecommunication, remote patient monitoring, or any other services you're furnishing via telecommunications must be on the plan of care, and they have to be tied to the patient's specific needs as identified in the comprehensive assessment. CMS also specifically said they're not going to require a description per se of how technology will help achieve the patient goals, but documentation in the medical record needs to explain how telehealth services are going to help facilitate patient outcomes. So that, in my mind, is pretty vague. You just need to know that if you use telehealth when you're caring for your patients, you have to explain or document somehow that telehealth is part of the care and how it's going to help achieve your patient goals. Also keep in mind that telehealth cannot replace an in-person visit that's actually ordered on the plan of care as an inpatient visit. Telemedicine visits are not billable at this moment, and no plan for that in the foreseeable future, I don't think. And it can't be used to establish eligibility. So make sure you're not using a telemedicine visit as a first billable visit. All right, we'll move on. Okay, let's talk about PDGM. We're all familiar with that. It's not changing for 2021. You still have those 5 variables that make up your HIPS code. There's 432 case mix categories that you see listed on the right, and I put that in there so you can see the calculation, how they come up with the 432. You have your admission source, community or institutional, and that is claims-based. You have your timing, early or late, which is also claims-based. You have your functional grouping from your primary diagnosis, and that is also coming from the actual claim. And then you have your functional impairment level. This is the only OASIS-based variable, and it comes from 7 of your ADL questions and your risk for hospitalization for a total of 8 different items that make up that functional impairment level. And then you have your comorbidity adjustment that comes from your secondary diagnosis, and that's also claims-based. None of that has changed for this year. All right. Some other things that haven't changed, the 30-day payment period. January 1st, 2020 brought PDGM, and with it came that new payment model of the two 30-day payment periods in each 60-day episode of care. That's going to stay the same. The LUPA thresholds and the case mix weights established for year one of PDGM will not change for 2021. The rural add-on that was previously established for calendar year 2019 to 2022 is also not going to change, but what did change is there's a realignment of 34 counties went from urban to rural, and 47 counties that were considered rural, they went to urban, or will be going to urban, went in 2021. These changes may have a negative impact on the wage index for some areas, so CMS has put a 5% cap on any decrease in the geographic area wage index from last year. The COVID-19 waivers have aligned the home health value-based purchasing requirements with the home health quality reporting program during the public health emergency, and that's going to continue. What that means is those agencies in the value-based purchasing states, they did not get penalized if they didn't submit data during the period of October the 1st of 2019 to June the 30th of 2020. The waivers are also going to delay the transfer of health information quality measures, and the standardized patient assessment data elements are going to be delayed until January 1st of the year that's at least one full calendar year after the public health emergency ends. So if the public health emergency doesn't actually be declared as ended before the end of 2020, and it happens in 2021, then your those standardized patient assessment data elements will not go into effect until 2023. That's just something to think about down the road as the public health emergency continues. Whenever that is actually declared ended, that's when the clock will start ticking for when those elements will come into effect. Also, non-routine supplies, are no longer a separate money since January 1st, 2020, when they were included in the PDGM reimbursement model. That's not going to change either for 2021. And DME provided as a home health service is paid at the fee schedule amount and is not included or bundled into the 30-day payment amount. All right, let's talk a little bit, if you'll go to the next slide, about review choice demonstration. It's alive and well. It's going to continue for 2021. You see the affected states. Those haven't changed since they were changed originally. You've got Illinois, Ohio, Texas, Florida, and North Carolina. Illinois, Texas, and Ohio have been doing RCD long enough for them to have made at least one subsequent review choice. So Texas and Ohio just made theirs recently. Florida and North Carolina is voluntary at this moment, and that's effective until January 1st, 2021. And unless something changes between now and then, it's going to be mandatory as of January 1st, 2021 for those states also. Illinois, Ohio, and Texas were given the option to pause during the public health emergency. If they were doing pre-claim review, they would not have been subject to that 25% payment reduction, but the periods that agencies chose not to get a UTN for would have been subject to review. So my understanding is that most agencies went ahead and continued on with PCR just to avoid any problems, but there were those that may potentially have some reviews based on their choice of whether they paused or not. Okay, that's kind of a quick summary of the what hasn't changed. I'm going to pass it over to Kim now, and she's going to talk about what's new.
Thank you, Lisa. So CMS estimates that Medicare payments to agencies in 2021 will increase in the aggregate by about 1.9%. This figure does take into account the behavioral adjustments made by CMS based on what they expected agencies to do, what changes they expected to see in response to the new regulations. Agencies will still be required to submit a RAP at the beginning of each 30-day payment period. This will establish the home health period of care in the common working file and trigger the consolidated billing edits, but there will be no payment for RAPs. The two value codes, 61 for place of residence where service is furnished and 85 for where the county where the service is rendered, will be optional. The only diagnosis codes that will be required for RAP submission is the primary diagnosis. All of the other diagnosis codes are optional in 2021. In 2022, the one-time NOAA or Notice of Admission will replace the no pay RAP. The NOAA is similar to the NOE, which is a Notice of Election that has already been used effectively for hospice. They tell us that the information needed for submission of RAPs in 2021 will mirror the one-time NOAA process. So basically in 2021, we will have the no pay RAP that is submitted for each 30-day payment period. But in 2022, things will shift to the NOAA, which will only be required at the start of care. Now, they have not released very many details about the NOAA, so we'll kind of have to hold to see where that goes. Agencies are to submit their RAPs when the appropriate physician's written or verbal order that sets out the services required for the initial visit has been received and documented, and the initial visit within the 60-day certification period has been made and the individual is considered admitted to home health care. So notice that it does not require orders for the full episode, just the initial visit at the start of care. So the admission visit must have been done and the patient considered it as admitted, but it does not require that the paperwork is completed, the OASIS is done as it has in the past. For research, the first billable visit is no longer required, so that will not be an issue, and we'll talk a little bit more about that later. So basically then what this means is there will no longer be a requirement to have an OASIS assessment that is complete, locked, or export ready, or a requirement for the plan of care that's been established and sent to the physician. So you will not have to have that OASIS completed and that 45 out the door anymore. In instances where the plan of care indicates more than one 30-day period of care will be required, agencies will be allowed to submit RAPs for both the first and second 30-day periods of care at the same time. Any valid HIPS code can be used on the RAP for submission, and the final claim must have the same HIPS as the RAP. Now, they do not have to match the HIPS calculated by the OASIS data. And as Lisa was alluding to earlier, the actual HIPS is generated by CMS from just those few items on the OASIS, and everything else comes from the claims data in the Medicare system. Next slide, please. So, no pay RAPs must be submitted and accepted within 5 calendar days after the start of care date for the first 30-day period, and within 5 calendar days after the from date for the second 30-day period and subsequent periods. So when you're calculating the 5 calendar days, the start of care date, if it's an admission, or the from date on the 30-day period for all subsequent episodes are considered day 0. There will be a non-timely submission payment reduction of 1/30th for each day from the home health start of care date or admission date, or from the from date for any subsequent 30-day periods until the agency submits the RAP. Now, again, remember the start of care or the from date is considered day 0. So that means a start of care with a January 1st start date will have to be submitted on or before January 6th to be considered timely. To illustrate this, let's look at this example. If you have a start of care on January 1st with a CMS calculated payment of $1,000 and it is submitted on January 7th, which is 1 day late if January 1st is considered day zero, then you would have a payment reduction equal to $200 or 6/30ths of your payment, because they do not calculate this penalty based on your first day late, your second day late. They go back to day one. So with this in mind, if you're late even 1 day, you're going to see a 20% reduction in your payment. And that is obviously not something any agency wants to see occur. There will be penalties that apply to LUPAs and outlier payments as well, but the LUPA penalty will be calculated differently. You can still have a no wrap LUPA in 2021, but if the utilization ends up being over the LUPA threshold, in other words, it's no longer a LUPA because you had to add nursing or some other service back in that you weren't anticipating, in that case, then the late wrap penalty will apply. So what they will do is, if you file a late wrap on a LUPA, any visit completed prior to submission of that wrap will not be paid. So this means there could be instances that the penalty percentage could actually be higher than it would on a non-LUPA wrap, depending on where that wrap got filed and how many visits got done prior to that filing. Now, there is no penalty if no visits were completed before you submit that late wrap. Your agency needs to determine whether it will send a wrap for all LUPAs or decide on a case-by-case basis. However, think about it. If you know that you have a LUPA and the wrap submission is already late, don't submit a wrap, because you can still do that. So fortunately, as you will see in later slides, KanTime's new dashboard alerts will make it easy to track and submit all your wraps in a timely manner and avoid those penalties. If a penalty is incurred, these days would be considered a provider liability, and the provider may not bill the beneficiary for them. The payment reduction cannot exceed the total payment of the claim, so they can't penalize you enough that you actually end up paying more than you would have made on the claim. CMS has said they may waive the consequences of a non-timely filed wrap if they determine that a circumstance encountered by a home health agency is exceptional and qualifies for waiver of the consequence. Next slide, please. So the following are circumstances CMS has specifically stated meet those criteria: fires, floods, earthquakes, other similar or unusual events where the agency receives extensive damage and it affects their ability to operate and service their clients. If you have a CMS or Medicare contractor systems issue that is beyond the control of the agency, they will consider that. Any newly certified agencies that are notified of that certification after the date, or they're awaiting their user ID, then that will be an exception. And notice all of these are saying things that are beyond the agency's control. So if something happens and CMS considers it something you should have been able to control, it is very likely you're not going to get an exception granted. But then they also added that other situations deemed by CMS to be beyond control of the home health agency, again, it's vague. It leaves room for other unusual circumstances, but they emphasize the fact that it has to be something beyond your control. So to request an exception, should this occur, they've said you should enter the condition for the exception request in the remarks section of the final claim. So if there was a situation where you were in a hurricane and you lost your internet service, your ability, something happened that it was beyond your control, then you would enter those remarks there, and you would append the HIPS code with a KX modifier, revenue code line 23 of the final claim. Now, be aware that if you do submit a late wrap and request an exception, the MACs have been instructed to request supporting documentation. So they're not probably simply going to take your word for it. Very likely, if you do so, they're going to ask you to submit additional documentation to support that request.
Lisa, thank you so much for joining KanTime today and providing the validity that having a consultancy like Mac Legacy, and Kim as well. My goodness, you've forgotten more than I know. So you really had some high-level folks here to provide you with answers. And of course, we're always available to you should you want to reach out to us after the webinar today. With that, I'm going to close. Everybody have a great day. Please stay safe.